How's everybody doing today? Sorry, we're having some technical difficulties, and so we're probably about 35 minutes late. Today, I wanted to just talk a little bit about hip pain and to go over sort of the common causes of hip pain, which are musculoskeletal in nature, versus some of the types of peripheral nerve problems that can cause a lot of hip pain. So first of all, we should maybe discuss some anatomical terms. The hip is sort of or the word hip is sort of a generic term that people will use to describe pain in the front, the side, or the back of the pelvis on one side or the other. Words like groin and buttock are also commonly used, and these are likewise not as specific or not super specific, although buttock would generally sort of point to something in the back of the pelvis, and groin would be something in the front of the pelvis, and then hip, the way I think it's most commonly used, would be something to the side of the pelvis. So let me just run quickly over a number of common orthopedic type problems or musculoskeletal problems that can produce pain in these areas that people might describe as hip pain. First of all, by far and away the most common one would be degenerative arthritis involving the hip joint itself. So where the ball of the femur fits into the acetabulum of the ilium. That's probably the most common type of or reason for having quote unquote hip pain, just degenerative changes, or you could have an injury to the labrum, those kind of things. Surgery for those problems would involve a total hip replacement or an arthroscopic procedure to fix a labral tear or, fix whatever other kind of problem that was present in the hip joint. Muscle inflammation or tendonitis involving the iliopsoas muscles. These are the big muscle group that flexes the hip. That's when you pull your knee up towards your chest. That's flexing your hip. So that could cause a lot of pain in the front of the hip. Moving around to the side, a very common source of hip pain would be trochanteric bursitis. The bursa is a little fluid-filled sac that rests between soft tissue and bony prominences to kind of cushion the soft tissue. So there's a very common problem to the side of the hip, which is inflammation of that greater trochanteric bursa. IT band syndrome, so the band of tissue that goes from your hip down to the outside of your knee, if that's inflamed or aggravated, that can cause hip pain and pain that radiates down the outside of the thigh. Moving around to the back, obviously, any kind of problem with the hamstrings could, cause pain around the sit bone area. SI joint problems can cause low back pain and pain that might be described as buttock or hip pain as well. So those would be the common orthopedic problems that could result in hip pain. Now, those types of problems are very well understood by most doctors and can be readily diagnosed by physical examination, diagnostic injections like into the hip joint or into the bursa sac, for example. And then MRI imaging is very good at, or X-rays or CT scans are very good at identifying things like, problems with tendons or muscles or arthritis in a joint, for example. Now, there's a lot of peripheral nerves in this area. It's probably one of the most complicated areas of the body in terms of nerves that overlap and whatnot that can cause pain in the front, side, or back part of the pelvis and could be described as hip pain. Probably the most efficient way to do this would be just to start if you sort of draw a line down the middle from your head to your toes, separating you into two halves. Each half would be symmetrical. So that's the midline. And we'll just, obviously it's the same, so we'll just use one half as an example, but starting in the front and near the midline, probably the first type of a nerve that could be injured that might cause, groin or hip pain would be some nerves called the ilioinguinal, iliohypogastric, and genitofemoral nerves. These are nerves that innervate the very low abdominal wall. In men and women, if the genital branch is a problem, you could get labial pain or testicular pain, scrotal pain. And then the ilioinguinal nerve can cause pain that radiates down into the upper inside of the thigh. These kind of nerves are very commonly damaged from surgical procedures such as laparoscopic procedures or a hernia repair procedure like an inguinal hernia repair, vasectomy, just any kind of surgery in that area or trauma to that area could injure those nerves. As you go from midline and start to go around to the back of the pelvis, the next nerve that you could encounter would be the obturator nerve. The obturator nerve is a nerve that innervates the muscles and innervates some of the skin on the inside of the thigh. So if you're sitting in a chair with your knees spread apart and you pull your legs in together so that your knees touch, you're using the obturator nerve to use those adductor muscles to pull your legs together, your thighs together. The next nerve is a nerve called the femoral nerve, and it's a big nerve that innervates all of your anterior thigh muscles, your quadricep muscles. It also gives sensation to the inside part of the skin over the thigh, and then also the terminal portion or the longest part of that nerve becomes the saphenous nerve, and that innervates the skin over the front of the knee and down the inside of the lower leg to about the ankle area. Now, both the obturator nerve and the femoral nerve are not nerves that are commonly a problem unless you have trauma or some kind of surgical procedure. In other words, these nerves don't pass through naturally tight spots like many of the other nerves that I operate on. And so it's rare, even in patients who have some kind of underlying metabolic process that predisposes them to nerve compressions in lots of areas. It's rare that these two nerves become compressed spontaneously. Usually there has to be trauma or surgery that causes bleeding in and around these nerves, which then cause a big inflammatory reaction and scarring and contracture of the tissue around them so that they become stuck in scar or compressed and then become symptomatic. Both of those nerves, the obturator and the femoral nerve, can cause a lot of groin pain, which could easily be misdiagnosed as hip joint problems. But there would be other clues too. So, with a femoral nerve problem, you tend to see weakness of some degree with the quadricep muscles, your anterior thigh muscles, or with adductor muscles, etc. And also you would commonly see or expect to see problems with the skin in the area that these nerves innervate. So the inside of the thigh, the inside of the lower leg, there should be some numbness, tingling, those kind of symptoms. As you continue moving towards the side of the hip, but you're still in the groin area, the next nerve that can be a problem is the femoral branch of the genitofemoral nerve. And it's a little nerve that innervates some skin in the upper anterior portion of the thigh. So again, any trauma to this area or surgical procedure that causes bleeding or might directly injure this nerve could cause a lot of anterior groin pain again, because this nerve is right on top of the hip joint area. And then moving further laterally, a very common type of nerve problem is one called neuralgia paresthetica. And this involves the lateral femoral cutaneous nerve, not to be confused with the femoral nerve, which is the big nerve that innervates all the muscles in the anterior thigh and the skin over in the front and inside of the thigh. The lateral femoral cutaneous nerve innervates the skin over the front and outside of the thigh. So if you drew a line right down the middle of your thigh from your groin to the kneecap, the inside of that line is typically innervated by branches coming off the femoral nerve or the obturator nerve, and outside of that line towards the outside of the thigh would be innervated by the lateral femoral cutaneous nerve. So the lateral femoral cutaneous nerve does not have motor function. So it's a purely sensory nerve. But compression of that nerve happens right near where the inguinal ligament meets the anterior superior iliac spine. So the anterior superior iliac spine is the bony prominence right in the front of your hip, sort of where your belt rests if you're a guy. If you kind of put your hands on your hips, you're sort of touching that area with your fingers. This is where the lateral femoral cutaneous nerve exits the pelvis and travels onto the front of the thigh to innervate that area. And so it can be pinched right as it comes underneath that inguinal ligament. And so you can have a lot of pain in the anterior thigh area, again, from this kind of a problem, which can be easily misdiagnosed as either a hip joint problem or a problem with the iliopsoas muscles, tendonitis or something like that. As you come around to the side of the hip, like when you see these old westerns with the cowboys wearing their 6-gun sort of on the side of their hip, that area, a part of the lateral femoral cutaneous nerve wraps around, that lateral branch wraps around into that area. Also, there's a branch coming off the iliohypogastric nerve, which travels directly over the side of the iliac crest or the hip bone to the side, and goes down into that lateral hip area. So trauma, again, or surgery to the side of the hip can cause damage to those nerves, and that could be easily misdiagnosed as a trochanteric bursitis or an IT band problem. Problems with the lateral femoral cutaneous nerve, which is also known as a condition called neuralgia paresthetica. So neuralgia paresthetica is a problem with the lateral femoral cutaneous nerve. Any problems with that nerve are often misdiagnosed as IT band syndrome because it'll be that sort of front outside part of the thigh that's affected. But it can also cause a lot of pain right up there by that bony prominence, and somebody could easily describe that to their doctor as hip pain. Now, as you go further around, now you're getting into the territory of the buttock, the big gluteus maximus muscle in the back of the pelvis. There's a number of nerves which could cause pain in this area. The first one would be the superior cluneal nerves, which can be compressed or pinched where they come over the back of the pelvis bone, and then they innervate the skin and soft tissue over the buttock muscle. Now, as you go a little bit higher, so the superior cluneal nerves are the medial cutaneous branches of the lumbar nerve roots of L1, L2, and L3, technically, although they do include L4 and L5 in the real world. But as you go higher, then these medial cutaneous branches also start to spread out laterally. So that's another source of pain that could produce both back pain and a lot of pain into the lateral buttock or even the lateral hip area. Middle cluneal nerves, which are these little cutaneous branches or dorsal rami, which come out of the back of the sacrum, and those sort of head directly laterally over the middle part of the buttock and even into the lateral hip area. So problems with the middle cluneal nerves could be perceived as buttock or hip pain as well. There's a condition called piriformis syndrome, which is entrapment of the sciatic nerve between part of the bony pelvis and the piriformis muscle. And that's a common source of sciatica pain, but one common feature of that is deep buttock pain, and often patients will actually describe it as hip pain because a lot of the pain radiates out towards that greater trochanter, that lateral hip bone. So patients will take a finger, I'll say, please point to where your hip pain is, and they'll actually put the finger in the buttock muscle just behind the greater trochanter. So this is where a lot of that radiating pain from a piriformis muscle can be experienced, as well as pain that radiates down into the back of the thigh and even up into the low back. And probably the final nerve that might be responsible for creating some quote unquote hip pain would be the posterior femoral cutaneous nerve, specifically the inferior lateral cluneal nerve, which innervates that the bottom outside part of the buttock muscle. Well, it doesn't actually innervate the muscle tissue itself, but that quadrant of the buttock, that low outside quadrant, is is served by that inferior lateral cluneal nerve. And so injury to the posterior femoral cutaneous nerve plexus could cause a lot of sort of low lateral hip pain. So you can see that when somebody comes in and complains to their physician of having hip pain, you can run into trouble pretty quickly by not recognizing all the different reasons why somebody could have hip pain. Again, the system is pretty good at identifying any kind of musculoskeletal source because it shows up well on imaging and people are familiar with how it presents and know what to do. And so any one of those kind of problems that fall into the purview of the orthopedic surgeon is usually going to be diagnosed correctly and treated correctly, and the patient's going to get better. The danger really is where the patient is dealing with a combo orthopedic and peripheral nerve problem, or just a pure peripheral nerve problem, because many of these nerves can closely mimic the type of pain that you would have with the more common orthopedic problem. So I've seen patients who, for example, have a femoral nerve compression or more commonly a lateral femoral nerve compression, lateral femoral cutaneous nerve compression, who end up with, a hip scope procedure or even a total hip arthroplasty, a hip replacement, thinking that will resolve the pain. And of course it doesn't. It typically will make the pain worse. People that, I think the key is, like, if you have pain that has a very unusual presentation, meaning your orthopedic surgeon's kind of looking at you with a quizzical look on his face, it doesn't really fit well into a specific box, or if you had some kind of procedure to fix pain that has been diagnosed as a certain type of musculoskeletal problem and it doesn't do anything for it or makes it worse, then you really need to start thinking about a peripheral nerve problem as the source of the pain. I think that's basically everything that I sort of have to discuss regarding hip pain. That part of the pelvis is pretty complex, and so you have to be careful when you have to be careful about you have to be really careful about making the diagnosis and making sure that you're, treating it appropriately. And I know there's some questions. Let's see. I know people have questions, but we had some technical difficulties with this, so I'm using an iPad to do this, and I cannot see the questions. I can see comments sort of, well, let's see. Maybe this is it. Okay, let me scroll back. I think I got it now. Okay. So this is a patient who's contemplating on coming to see me, and this is a question about getting blocks done with Dr. Fabito. So I typically don't do a lot of my own blocks, especially ones that need imaging guidance or are deeper. I have a colleague who's a very good pain management physician who does these blocks for me. His name is Dr. Fabito. And the question here is, can this patient come and get these injections, these diagnostic blocks, and have surgery in one trip, or will it take 2 trips? And the answer to that is it all depends on what the problem is, how complex the problem is, and how clear the diagnosis is after blocks. And also, where the blocks happen and which nerves are being blocked. In a situation where the nerve is being blocked, I don't have to operate directly where the block is, and if the nerve's fairly large, then you could potentially have the diagnostic procedure and surgery done at in the same trip. On the other hand, for something like superior cluneal nerves or middle cluneal nerves, you have to operate and find the nerves right where the block happens, and these nerves are small, and with injections, there's going to be bleeding that gets stirred up around the nerves, and so I like to allow the body at least 4 weeks to sort of scavenge all that blood and make the tissue planes and the tissue look normal again, because when everything's stained red, it's a lot easier to miss a tiny nerve that you need to find, and that can lead to a poor outcome for the patient. So it's sort of a case-by-case basis as to whether or not somebody can come out and have everything done in one trip or may need 2 trips. Let's see, looking for more questions here. This one says, why do peripheral nerve surgeries sometimes fail when performed by orthopedic surgeons? Can piriformis syndrome cause big toe numbness? So I would just say orthopedic surgeons are not trained to do peripheral nerve surgery. I mean, unless you're talking about somebody who's come from an orthopedic background and done a hand and micro fellowship and is doing something like carpal tunnel surgery or ulnar nerve surgery. Yeah, they can do that. If they've been trained well, they can do that. There's no reason why they can't. So when they start straying off into, doing nerve surgery in the lower extremities or somewhere else, like trying to treat piriformis syndrome, they just really don't have the background to know how to do these surgeries properly. Like when you're decompressing a nerve, there's certain things that you have to do in certain areas that you have to decompress completely. And if you don't understand the anatomy and don't understand what needs to be done, then you're not going to do a good operation for the patient. Also, this topic that we've discussed here today about hip pain or pelvic pain, however you want to describe it, as you can see from the discussion, it's a very complex area in terms of nerves that are close together, nerves that overlap each other. And so, there's no orthopedic surgeons on the planet that understand the nerve anatomy in this area well enough to consistently get good results by trying to do some kind of peripheral nerve procedure, because number one, they're going to misdiagnose the true source of the pain a lot of time, operate on nerves that might not really be a problem, or do an operation that they don't really understand how to do. And a classic example of that is piriformis surgery. Most orthopedic surgeons will do some kind of a release when it comes to piriformis surgery, and that's not the right operation for that condition. So if you leave the muscle in, the patient's going to have a lot of problems down the road. Another question here. Oh, back to that first one. Sorry. It says, can piriformis syndrome cause big toe numbness? The answer is yes. Piriformis syndrome can cause a lot of pain and numbness that seems sort of isolated to the big toe, but there's other peripheral nerve problems further down the chain that can also do that. So you'd have to have a physical examination to know for sure. This is a patient says, I've been having undiagnosed bilateral sit bone pain for more than a year now. So a lot of pain was sitting right in the vicinity of the ischial tuberosity. Says there's no bone problems by x-ray, no tendonitis by pelvic MRI, no lumbar problems by lumbar spine MRI. There's no anorectal or genitalia pain and no groin pain. So we know it's not a pudendal nerve problem, which innervates the anorectal and perineal area and genitalia and all that. It says no groin pain, no pain in doing all sorts of hamstring or other loading exercises, but almost instant bilateral sit bone pain when sitting on a bike or a hard floor. I described the pain as achy, discomforting pain. No numbness, burning, or tingling, really. Could it be a PFC or pudendal nerve problem? So it's unlikely to be a pudendal nerve problem because, again, there's no anorectal pain, no perineal pain, no genitalia symptoms. And that's if you have a pudendal nerve problem, you're going to have that kind of pain. Sit bone pain, just generally, the pudendal nerve doesn't really innervate the area of the sit bone. The most likely situation there, especially if you just have isolated sit bone pain, is one of two things. You're probably dealing with the perineal branch of the posterior femoral cutaneous nerve. The posterior femoral cutaneous nerve is really sort of a plexus of nerves, and there can be one or more branches that come off that wrap right around that ischial tuberosity or the sit bone. And so those nerves can become a problem if somebody sits a lot in their job or has had a fall where they landed hard on their buttock or any number of reasons. And one misconception is that if you have a sensory cutaneous nerve that's damaged, you got to have a lot of numbness and tingling. That's not the case at all. I see many patients with myalgia paresthetica or a problem, compression of the lateral femoral cutaneous nerve, for example, where they don't really have a lot of numbness or tingling of the skin. It's really more of a deep, achy sensation in the thigh. And so that's true anywhere else. The way to figure out what kind of a nerve problem this is a diagnostic block. There's another less common nerve that could be going, or a problem that could be caused by this nerve, and it's a nerve called the perforating cutaneous nerve. And this is a nerve that nobody really knows how commonly it's present, but if you look in the literature, it's maybe 20-25% of people, or more. It just depends on what you look at. But I don't think it's very common. This is a nerve that will come off as a branch of either the lower middle cluneal nerves or the pudendal nerve, and it tends to pierce through the sacrotuberous ligament and then kind of come out over that ischial tuberosity or the sit bone, and it innervates the medial lower part of the buttock. And so I actually had a interesting patient the other day who at the very beginning, his problem was actually a compression of that nerve. The nerve can become compressed where it passes through the sacrotuberous ligament. And he ended up having a hamstring surgery to try and deal, because that's what they thought the source of that pain was. He had a lot of low inside buttock pain around the ischial tuberosity. He was diagnosed with a hamstring problem, had a big surgery to reconstruct the hamstrings, and that surgery actually injured his main posterior femoral cutaneous nerve. So the first thing I did was disconnect the PFC and plexus, and that resolved the pain that occurred after his hamstring surgery, but left him with his very original pain. And so then I was able to diagnose it via diagnostic block that it was actually this kind of a problem, and go in and find that nerve and disconnect it. And so he's doing really well now. But it's pretty astute of this patient to narrow it down to posterior femoral cutaneous or pudendal nerve. So good job. Let's see. There's a question here that says, I was diagnosed with myalgia paresthetica. So again, that is a problem with the lateral femoral cutaneous nerve. It says, can sugar make the pain worse? Because sometimes the pain is more tolerable. Other times it's like a tiger ripping open my leg. Doctors here just throw gabapentin and Vicodin scripts at me. I plan to see you soon. Yeah, that's an interesting observation. I have had patients who describe diet as definitely impacting their pain level, whether it's salt or sugar in this case. One thing about sugar is that when you eat sugar, the sugar is taken into the bloodstream, and the body does not like high levels of glucose in the bloodstream, so it'll take it tries to pull it out of the bloodstream by absorbing it up into muscle tissue for one, and another type of tissue that sequesters glucose is nerve tissue. And what happens when glucose is taken into the nerve, it's changed into another type of sugar called sorbitol, and there's an osmotic effect. What that means, if you remember, like maybe in your science class in high school, where they have a container with a semi-permeable membrane separating two different liquids, and you dump a bunch of salt in one liquid or one side of the container, so that one side has very salty water, the other side has fresh water. Pretty soon, all the water will transfer over to the side that's salty to try and dilute it down. And that's what happens basically in the nerve. The nerve takes up glucose, it's changed into sorbitol, and that causes water to be pulled into the nerve after the sorbitol to try and dilute the concentration. And what that ends up doing is it causes the nerve to swell. So one potential explanation is that when you eat sugar, it's causing your nerves to swell transiently, which would actually increase the amount of pressure that's on a nerve that's already compressed. There could be other explanations, but if there is, we don't really understand that very well. Another person here says, I started in February, which I thought was static pain. I think maybe she meant sciatica pain. I went to a chiropractor who told me I had piriformis syndrome. The pain goes from outside my thigh down into my foot. Last week I got steroid injections. Yes, it helped, but now my pain has moved just below my hip, though no pain like I had before when she was sitting. So, this is a pretty reasonable story for a piriformis syndrome. The way to figure this out is first to get a lumbar spine of an MRI of the lumbar spine, just to make sure that this is not a herniated disc pushing on an L5 nerve root, for example. If the lumbar spine is clean, then the chances are very high that it's piriformis syndrome. I don't know where they injected the steroid, but it doesn't matter so much because steroid, if injected anywhere in the body, has a very powerful anti-inflammatory effect and can reduce swelling and inflammation. And so that could help the pain to some degree. Steroid, for somebody who has a severe piriformis syndrome, it's unlikely that that's going to make it go completely away or go away permanently. It might take it away for some period of time or really reduce the symptoms for some period of time. But most likely, if there's a true piriformis syndrome present, these symptoms will come back. So I think it's a very good chance that that this patient is dealing with piriformis syndrome if the MRI of the lumbar spine is normal. There's a question about a doctor that did some blocks for this person in the past is no longer offering these blocks. I would just say for anybody who needs special blocks to try and diagnose nerve problems, often our office, we've built up sort of a network around the country of pain management doctors that can do blocks competently. And so, you might have to travel, but there's likely someone in your region that could do these blocks. Or there's always the option of coming to Las Vegas and having blocks done by Dr. Fabito, who's very good. This patient has the question, is there someone I can talk to about which airport to fly into, where to stay while there, and other logistical information? I mean, anybody who's considering coming to Las Vegas to have a consultation with myself, my office can handle all that. So you just have to call my office and they can give you any of that information that you need, especially if you're coming from out of the country. So this sounds like a mother of a son that's affected with chronic pain. She says, "We're from South Africa. My son lives with chronic pain. He has numbness in his anterior medial thigh, very bad anterior knee pain, and then lower leg pain from the knee down. Some heel pain too. What would be your first thought as to what could cause this? He has had knee surgeries, but nothing helps the knee pain. Is this perhaps femoral nerve related?" So that's a good thought. Depending on, if there was some trauma that happened first, resulting in the need for a knee surgery. I don't know how old your son is, but especially if he's a younger person, generally there's usually some kind of traumatic injury that leads to the necessity for something like a knee surgery. Anytime there's trauma to the knee or there's a knee surgery that's been done and then the patient ends up with a lot of pain like this description, you think of the saphenous nerve, which is that sort of long terminal branch of the femoral nerve. If you think the femoral nerve itself is involved, usually there's going to be more general achiness over the anterior thigh and also some weakness with knee extension because those quad muscles will be weak. But if the problem is just compression of the saphenous nerve in the adductor canal, so that's deep in the medial thigh, or there's been injury to the medial infrapatellar branch of that nerve as it wraps around the front of the knee, and so very often any type of knee surgery can irritate those nerve branches. And so somebody with that kind of a problem could have a lot of radiating pain in the medial thigh, the inside of the thigh, into the front of the knee, and also pain that might radiate down the front or inside of the lower leg between the knee and the ankle. Heel pain is typically not a problem with the femoral nerve. But again, if there was some kind of traumatic injury that damaged the knee bad enough to require knee surgery, those kind of injury mechanisms can affect more than one peripheral nerve. So there could be other nerves that are now compressed or irritated in some way. But it sounds like the saphenous nerve, if it's front and inside of the thigh, front of the knee, and down the lower leg, front and inside of the lower leg, then that's a very likely source of the problem. Next question here says, I have pain radiating through the buttock, down the leg, as far as the upper calf, sometimes pain directly on SI joint. I have had normal lumbar MRI. Pelvic MRI was normal with no piriformis enlargement. I have had SI joint and piriformis injection with no improvement. I had dynamic EMG targeting piriformis that did show some problems with the problem side, 1.25 milliseconds slower in fair position. My doctor is stumped as to what I have since the imaging is normal and no improvements with injection. The pain is primarily with sitting. Could my pain be some peripheral nerve pain other than piriformis syndrome? So if you have pain sort of in the buttock that goes down the back of the thigh and into the upper calf, it could be a posterior femoral cutaneous nerve problem. That's one possibility. If you here's where physical examination by somebody who knows how to examine these problems is useful, because if you have weakness with knee flexion, which is almost always present in somebody who has any kind of significant piriformis syndrome, then that rules out the posterior femoral cutaneous nerve at least as the sole problem. You can have piriformis syndrome and a posterior femoral cutaneous nerve problem depending on any number of circumstances, but classic piriformis pain is sort of deep buttock pain that goes down the back of the thigh and then will go into the upper outer part of the calf, usually, as opposed to the whole calf or the upper medial part of the calf. There's really no one size fits all with something like piriformis syndrome or any peripheral nerve problem. And that's why it can be hard to diagnose if you don't have a lot of experience, because you can have two patients, both who have piriformis syndrome, and they might present very differently. I will also say that with piriformis syndrome, You can have normal MR neurography of the pelvis and not respond to a piriformis injection and yet still have the problem. So there's no one thing that can be used to rule in or rule out something like piriformis syndrome. I will say that history and physical examination is much more important than whatever the patient, how they respond to a diagnostic injection or even any kind of MRI imaging. Diagnostic injections and MRI imaging is a useful additional step and can clarify things and sort of firm the diagnosis up, but it does not take the place of a very detailed history by somebody who knows what they're listening for, and then also a comprehensive lower extremity peripheral nerve evaluation. Let's see if there's any other questions here. This is an interesting question. It says, how many times can you have a perineal nerve decompression revision? So I'm assuming that they're talking about the common perineal nerve on the outside of the knee area. I mean, theoretically, as many times as you can find a surgeon to try and do it. But in reality, your best shot at a good outcome is the first one. If you have somebody who doesn't know what they're doing and doesn't do it fully, or injures the nerve or does something like that, then success rates after that start to go down. Now, if they haven't injured the nerve but they just didn't fully decompress it, or again, if there was some kind of misdiagnosis, so maybe the problem isn't just at the common perineal nerve level, or maybe it's not the common perineal nerve at all, and maybe something higher up like a piriformis syndrome. There's just a lot of things that could be going on as to why somebody might have a common perineal nerve decompressed and then feel like it didn't work, and then they do a revision on that and then another revision, and all the while the problem is somewhere else. You got to remember that peripheral nerves are like long strings that go from the spinal cord all the way to wherever they terminate. That could be the tip of the big toe. And so you could have problems existing at several levels along the course of that structure, and a compression or a problem with the nerve at one level may not actually produce nerve right where the problem is. It may not produce pain right where the problem is. The pain could be a lot further downstream. And so if you don't do a comprehensive exam every time on these patients, you might get kind of fooled into thinking, well, okay, it's just a common perineal nerve compression, and that could be part of the problem, or that might not be the problem at all. And they decompress that nerve thinking that that's going to solve the problem, and then the patient doesn't get better. So this question, it says, I saw you a few years ago and you diagnosed me with piriformis syndrome and peripheral nerve damage. I was curious if having a piriformis ablation to see how much relief I would get from that before having the actual surgery. The way this question is worded, I think this person is misunderstanding what an ablation is. An ablation procedure is usually done to nerves themselves, usually relatively unimportant sensory nerves, and it's done using basically what it does is it uses heat or sometimes cold to kill the nerve. So you can't really ablate a muscle. Piriformis, you wouldn't want to try and ablate your sciatic nerve, which is the nerve, because then you would lose total function in your foot and be numb in most of your leg. For piriformis syndrome, the treatment is to remove the piriformis muscle. It's not to try and do anything to the sciatic nerve itself. The problem is because the sciatic nerve is being compressed by the piriformis muscle, and so the treatment is to remove the muscle. So I would not recommend, I don't know if somebody is asking you or trying to get you to do an ablation of the sciatic nerve or what exactly, but you don't ablate muscles, and so that's not going to be effective. This question, do you think nerve issues can cause vein issues? Generally, no. You can have varicose veins. They can be painful. That's typically a separate issue and not directly related to nerve problems. This one says, how can a doctor tell for sure you have piriformis syndrome? Well, most doctors can't because they don't understand the condition well enough. You really need to see somebody who is a peripheral nerve specialist like myself, who knows how to examine you and the appropriate diagnostic workup. Now, having said that, if you get an MR neurography that shows, inflammation of the sciatic nerve where it passes underneath the piriformis muscle, if you've had a diagnostic injection into the piriformis muscle, which made your pain go away for 2 or 3 weeks or a month or something, then very likely you have piriformis syndrome. That's probably greater than 90% likelihood that removing the piriformis muscle will fix your problem. So this one asks, can you recommend a doctor calling in Germany? There's nobody there in Germany well, I don't know exactly what your problem is, so I'd have to know. But for something like the piriformis surgery that I do, or some of these other things, there's nobody that I'm aware of in Germany that really knows how to do that. If you needed headache surgery done, then you probably could find somebody that does that kind of thing. But so it all depends on what kind of a peripheral nerve problem that you have. This patient or person says pain around hip joint, but normal MRI, CT scan, X-ray, and ultrasound. What could be the reason? Sacroiliac joint is fine based on clinical examination and imaging. So again, it depends on, is this pain in the buttock or the back of the pelvis that goes down the back of the leg? Is this pain in the front of the pelvis or the groin area? Says they got a steroid injection and got better, but only after 2 weeks. Does it mean I have piriformis syndrome? I don't know that really means anything, like in terms of it's not useful diagnostic information. I just think that you'd need a much better workup than what you've had. And really, since all this imaging is negative and the usual musculoskeletal culprits don't seem to fit, then you're probably dealing with some kind of a peripheral nerve problem, and you just have to see somebody who really knows how to examine these kind of conditions in order to get a correct diagnosis. This person says, what is the typical recovery time after piriformis removal? In terms of recovering from the surgery, most people are sort of back, no more pain, somewhere between 2 and 4 weeks, I would say, for the most people. And then in terms of recovering from the sciatic pain or the nerve pain that you had before the surgery, that just depends. Most people who have clear piriformis syndrome notice very substantial improvement or even complete relief in the first few weeks after surgery. It's just kind of it's a principle that applies across nerves. Any nerve that's pinched, if that location is diagnosed correctly and the proper surgical steps are undertaken to relieve the pressure, the improvement in clinical symptoms in terms of the original pain is usually fairly rapid. I think it's the same people from South Africa says, we also think our son's pain is related to the saphenous nerve. We can't find any doctor to help us in South Africa. One thing you might be able to do in South Africa would be to definitively make that diagnosis, be to have somebody perform an ultrasound-guided block of the saphenous nerve in the adductor canal. The adductor canal is a tight space deep in the medial or inside part of the thigh. I mean, all the doctors in South Africa would be able to open an anatomy book and figure out where that is if they don't know it right off the top of their head. I would suggest finding a good interventional pain management or possibly an interventional radiologist, but interventional pain management would probably be better. Somebody who is good with ultrasound guided blocks, and they should be able to at least block that nerve and see if that really relieves the majority of his pain. Unfortunately, there is nobody in South Africa who does this kind of surgery, so you would have to travel to the U.S. Ultimately. This patient says, does the piriformis cause freezing sensations in the leg? The answer to that is yes. And the bigger picture is any nerve that's injured or damaged or compressed can cause or reproduce almost any sensation that you can imagine. If you just think about any sensation that you can experience by touching something or, whatever, that sensation can be reproduced when a nerve is injured or compressed or not happy for one reason or another. So it could feel like freezing, it could feel like burning, it could feel like somebody's, pulling broken glass over your skin. It can be almost anything. So, yeah, definitely can cause freezing sensations. Here's one that says, my doctor keeps suggesting hydrodissection as an alternative to piriformis surgery, but I highly doubt that a saline injection can substitute for piriformis removal. What are your thoughts? That's very perceptive of you, Lila. On the other hand, you could try it once. Doing hydrodissection, as long as they don't stick the nerve with the needle, there's not that much downside to it. I don't think it's going to make you better. Hydrodissection, when somebody has a chronic nerve compression, hydrodissection is has a very low likelihood of producing permanent or long-lasting relief. But my opinion is that hydrodissection for piriformis syndrome is not going to give you any kind of significant relief. But on the other hand, it's a lot less invasive than surgery to remove the piriformis muscle. So depending on how you think about it, you could certainly try it. It's a low-risk procedure, and just see if it helps you. And if it doesn't, you don't burn any bridges in terms of having the piriformis muscle removed later on. This says, can you recommend any specialists for hip-related pain and lower back pain that usually undiagnosed in any of these countries? Dubai, Jordan, India, Lebanon. Yeah, unfortunately, it's really quite tragic, but there is nobody else in any of those countries that does this kind of surgery. I have had patients come and see me from the Middle East, and I know that it's quite a difficult process to get visas and all that kind of all those hoops that you have to jump through. So, but unfortunately, there's nobody in these other countries that do it. I've sort of contemplated actually maybe going and setting up a center in the Middle East, somewhere where patients from those countries could come and travel to, but as of yet, I haven't done it. This question says, does EMG testing find out what is wrong with nerves? EMG testing is useful if you're talking about a damaged nerve or an injured nerve that has motor function that makes muscles move. Then EMGs can be useful in diagnosing and tracking recovery of those and can be used to make decisions about whether or not to surgically explore a nerve. But in terms of pain, the area that I specialize in, EMG testing is almost completely useless. It doesn't really give you useful information, and most neurologists don't understand the peripheral nervous system well enough to really make that useful anyway. There's lots of types of nerve compression that they don't even test for using those studies. So yeah, if your problem is pain, EMG testing is usually painful and not very illuminating as to what the problem is. let's see. And I think that's it for questions. So we got through all the questions. I hope everybody enjoyed that. Sorry for the technical difficulties, but we will do this again soon, and next time I'll target it more specifically to a topic like piriformis syndrome or other things. We usually look at the questions that are submitted to the website or to the Facebook page, and then try and look at which ones occur over and over, and try to talk about them. So one last question that came in says, do you do televisits? And my answer to that is no. And the reason is because I do have a system because most of my patients do not live in the state of Nevada. They come from other states, other countries. And so I have a pretty good system for figuring this out, but I don't like televising or doing the telemedicine stuff because, you can have a half-hour conversation, and then 6 hours later, the patient is wondering what I said about this or that, and it's hard to remember some of these things. So the best thing to do if you want me to evaluate is just contact the office. We have you sit down and think about the symptoms you're experiencing, and then I review that summary. The patient summary is what I term it. And then we go back and forth as needed until we figure out exactly what's going on. And, then I can suggest imaging or other diagnostic blocks that might be able to be done where the person lives. And ultimately the goal is, if they need some type of surgery, to really avoid a situation where somebody comes to Las Vegas and doesn't have a problem that I can help them with. And so, I have a good system for that in place, but a big part of diagnosing these problems involves a physical examination. I have to it's kind of old school. You have to actually, put your hands on the patient and examine them and figure out where these problems lie. And you can't do that with telemedicine. So, anyway, I will, see you guys next time. Thank you for dropping by.